Welcome everyone to today's webinar. We really appreciate you joining us. My name is Tyra London and I'm the Director of Marketing for American Nurse Today, and we are so happy that you have joined us. We have a great panel that will be discussing patient acuity and nurse staffing. Our webinar today will last approximately 1 hour, and we have allowed time with our presentations for a live Q&A session at the end of our panelist presentations. If you'd like to ask a question, please use the GoToWebinar dashboard, which appears on the right-hand side of your computer screen. Questions need to be submitted through that dashboard. If you are unable to view the full dashboard, please click on the orange arrow in the upper right-hand corner of your screen, and that should expand the dashboard function. The audience is muted during the webinar, so again, please use that dashboard for any communication, whether it be questions or any issues you may have. Approximately 48 hours from now, you will receive an email that will include a recording of this webinar. Please feel free to share it with your colleagues. Please comment back to us. However we can be of help, we hope that you'll contact us. The webinar will also be made available on AmericanNurseToday.com for a period of 6 months, should you want to go back to the archive and review any of the information at a later date. We do want to thank our other sponsor, General Electric, who has been kind enough to help sponsor this webinar today. Now I have the distinct pleasure of introducing you to your moderator today, Lily Jelinas, who is System Vice President and Chief Nursing Officer at Christus Health, and also we're thrilled to death that she is Editor-in-Chief of American Nurse Today. Good afternoon, Lily.
Hi, Tara. Thank you so much, and hello, everyone. We're excited to welcome you to this session on such an important topic. You know, the patient is at the center of our work, and staffing is an essential dimension of the entire patient experience. So balancing nursing workloads is a key performance imperative for hospitals and healthcare systems today. So to discuss this imperative, our plan for today is to review key research results related to acuity-based staffing, explain how to make the business case for acuity-based staffing, and share a case study of acuity-based staffing through the experiences of a large integrated healthcare system in Southwest Ohio. We'll also discuss next steps and help understand where to go from here. The benefits of acuity systems for healthcare organizations are multiple, and healthcare organizations today, we know, are implementing several strategies to enhance clinical and financial outcomes. Rapid is our new normal. So how do we know what changes will speed the improvement to better outcomes, especially at the bedside? Acuity-based staffing is one of the changes getting heightened attention, and in some states, as you'll hear, legislative attention. Acuity systems maximize patient as well as nursing outcomes through enhanced decision-making, improved operational outcomes, improved nurse and patient satisfaction, all while improving financial performance through lower costs. On your screen, you'll see the list of our esteemed panel of experts. So let's begin today's discussion with John Welton, who is Professor and Senior Scientist for Health Systems Research at the University of Colorado College of Nursing. Dr. Welton, welcome to the program.
Thank you, Lily, and my personal greetings to everyone on the webinar today. Staffing, from a nursing standpoint, is something that's dear to our hearts, and something that we really need to begin to think about in its broadest terms. Yes, we need to be able to make sure we have the right amount of nurses for a given set of patients, but it's more than just staffing. You have to begin to look at who's the actual nurse caring for a patient. How efficient and effective are our staffing systems and our nursing care delivery systems in meeting our overall clinical as well as operational needs? How well is the system performing? and what is, as Lily said, what is the cost of that care? And ultimately, I'm going to pose a question. We'll go through this in a few minutes. So what is the added value of each nurse caring for a patient? Next slide. One of the things that we know, and for those of us who've been in nursing for long enough, especially in the inpatient environment, we know that patients are sicker, they're much more complex care, and the care is quicker, as we said already. So that presents a number of different challenges for us to be able to modify and adapt our systems in order to provide optimum care. Next slide. One of the things that we do know, and this is where the cost piece comes in, if we look at nursing care, either a staffing ratio or nursing hours per patient day, there's a direct relationship between how many patients a nurse cares for, his or her wage, and the overall cost per patient day for a particular patient. The reason this is important because right now within our healthcare finance system, nursing care is invisible. It's basically just a room and board fee, and it's not reimbursed directly. So that this provides some challenges from an operational standpoint, from a finance standpoint, because the staffing ratios are directly related to the total cost of nursing care in a particular setting, and how does that relate to reimbursement? Next slide. One of the things that we know, and this is just two studies that I was involved with, and there's several others that are important to note, but that any particular patient has different care needs. For example, even the same patient has more or less care depending upon the day of stay. Say a acute pneumonia patient comes in on the first day, needs much more nursing care than the second or third day, assuming that patient's improving and getting better. We know on the left side, that is a study. We actually had nurses monitor and record their actual time for each individual patient. And this is just a single academic medical center, but we can see the wide variety. Patients on average receive between 5 and 15 or 10 hour per day difference, depending on their overall acuity. And even though the mean 9.7 hours is typical of an academic medical center, which included the step-down care, we see an awful lot of variability. On the right also, we see a lot of variability. This is all the hospitals, acute care hospitals in Massachusetts. We actually look at their staffing patterns and see a wide variety of variability. That's the importance as far as being able to understand what the patients need, their acuity, and the overall amount of nursing care time for each individual patient. Next slide. So let me pose a question. Our typical way of approaching nurse staffing is either to look at it, for example, at midnight census, how many patients, ratios, nursing hours per patient day, and all of these measures are an average of many nurses over many patients, and basically uses a single statistic to identify what the nursing care is, and that's an average. So what is an average patient? When we begin to think about it, the tools, the measures that we're using right now to understand staffing and changes in staffing are antiquated, that we need to come up with better ways to approach this and begin to have better ways of identifying the actual need and demand for nursing care, as well as the actual care that's delivered by each nurse. Next slide. This is a study we did also back on the East Coast. One of the problems we have is, and it was identified in that previous slide, that there's no alignment between the actual care, nursing care a patient receives, what's actually billed for care, which is a room and board charge, and the actual reimbursement, which is based on a patient diagnosis. This just shows some of the problems when we actually use medical diagnosis or medical severity as a way to explain nursing care. Sometimes it works fairly well. For example, on the two green highlighted areas, we can see that as the severity level, and this is within the all-payer refined DRG, goes up, that the nursing intensity, the actual hours of care went up. But then there are other times when the nursing care is high and stays high and doesn't really vary very much. So that's important for us to understand that medical care and nursing care are different. Even though we're caring for the same patient, that there are different requirements from both the medical and a nursing standpoint. We know a lot about the medical care as far as the diagnosis, the procedures, the testing and things, the labs, the pharmaceuticals that are used in patient care, but very little, if anything, about the individual care, nursing care that a patient receives. Next slide. This was a study where we actually, like the MUSC study, we're actually able to allocate nursing care time and dollars to each individual patient. This is 5 hospitals, 50,000 patients. I can't remember how many nurses. But what's interesting is depending upon the length of stay, the amount of nursing care hours varied. For example, patients that stayed 1 day required much more care per hour, per 24 hours, than patients stayed 4 or 5 days. The other interesting thing about this graph is that after 3 days of stay, older patients, 65 years and older, needed about a half to 3/4 of an hour more care than the younger patients. The horizontal line is the average of all these, which is a proxy measure of the nursing care hours per patient day. So you can see in the results of this study that using nursing hours per patient day really hides a lot of important and clinically and operationally meaningful variation in nursing care that's important for us to begin to think about how we can capture that, identify it, measure it, and then adopt that within our individual nursing care delivery systems. On the very right, we can see that there's a small group of patients that stayed a long time in the setting, and it's classic across the United States. These are some of the outlier patients that, even though they represented 20% of the of the patients that received nursing care, they consumed half, 50.4% of the total nursing care hours and dollars associated with that. So that outlier population requires another challenge within the inpatient settings. Next slide. This is another approach. Dr. Sharon Pappas, she's the chief nurse for Centura here in the Denver area, and was involved with this study. Even though it was just a single unit, it was a surgical transplant unit, they took the approach of identifying risk, and that was linking not only staffing levels, but assignment and the overall burden of the assignment based on different types of risk. For example, who were patients at high fall risk, who received a transplant or was in hepatic failure. And in that particular setting, it was very meaningful for them to begin to adjust the assignment level, not just the staffing, but the actual assignment. We can see before and after they introduced that intervention that across the board they saw reductions in pressure ulcers, falls, urinary tract infections, and bloodstream infections. So again, similar to Jack Needles speaking next, some of his work, it kind of begins to look at that at a much individual level in a single unit, and the importance in understanding what are some of the things that drive not only nursing care, but the outcomes of that nursing care. Next slide. Now let's talk a little bit about nursing care value. I'm involved with a project that actually comes out of University of Minnesota School of Nursing, addressing big data in nursing care. And this is one of the expert panels, the work groups. And one of the things, the questions we're posing is how do we actually measure nursing care value? And what was interesting as we began 2 years ago to begin to conceptualize that and identify it, how to measure that, we had to change that around and begin to think about how can we measure the value of each individual nurse caring for a patient. So again, as we begin to think about how to model that, we had to begin to look at the nursing care in direct relationship between the outcomes of that care as well as the cost or the price of that care. Next slide. So let's begin to think about that from a staffing level. Staffing is talking about a group of nurses and a group of patients. But from a value-based care standpoint, we're looking at each individual nurse as a provider of care at the bedside, and that we measure nursing care as that link between an individual nurse and an individual patient. We call this an encounter, but in an acute care setting, we would typically call this an assignment. If we were in other settings like home health care, it would be a home visit, or in a clinic, it would be a clinic visit, and so forth. And this is a data-driven focus in the sense that we're looking at not only that link between a nurse and a patient, but also differences in times, and taking that data and organize it in a way we could begin to look at not only staffing and assignment, but also cost, quality, performance, effectiveness, all those things that we talked about at the beginning here. And ultimately, our goal is to come up with new tools, new, much more data-driven and data-rich tools that can help us identify business intelligence and analytics that can help us in a real-time environment begin to look at nursing care in a much different way. The next slide, please. I'm just going to put this up. This will be in the slide set, and this was published in January, Nursing Economics. This is just the way, the model that we proposed out of our expert panel to extract the data in the electronic health record model it in such a way that we can ask and answer many different questions. Now, one of the good news is that we spend a lot of effort installing electronic healthcare systems, healthcare records, especially in acute care. So the data is being collected so that the burden to actually collect the kind of data we did back on the East Coast at MUSC, that's essentially eliminated. The challenge now is how do we get the data out of the computer and use that for many other different purposes. So that's what this model is. It's just a way to extract the data in a certain way, a certain form. It retains that relationship on the right side between a nurse, her credentials, experience level, and so forth, with the individual patient on the left-hand side. And then in the middle, what were some of the problems, the interventions that nurses were doing, and then the outcomes of that. So it's a way to answer how do we measure nursing care value in using the actual data. It's vendor agnostic. It's not related to a specific software program, and it's setting neutral that we can use this in many different settings, not only acute care, but outside care, home health care, clinic, and so forth. Next slide, please. I'm just going to basically just talk about nursing finance real quickly. We really can't talk about staffing without really talking about the costs of care. Nurses represent 25 to 30% of a hospital's operating budget. That's a huge amount of cost. And by using the data that I just mentioned, it gives us the ability to look at the nursing input, the nursing component of the business of caring. So when we talk about staffing, as that slide a few minutes ago showed, that there's a relationship between the actual nursing time and the actual nursing dollars that are expended for a particular patient, whether you calculate as a ratio or nursing hours per patient day. But if we're trying to orient ourselves towards value, we have to look at how we expend those dollars wisely and how that's related to the overall cost and quality of the care that we're expending wherever it may occur. When we have those data, we can begin to look at nursing care in a very, very different way. I'm just going to sort of plant a seed today and sort of put that out as a teaser. But for those of you, especially at the bedside, if we had the ability, we do have the theoretical ability to go ahead and measure care at that individual nurse patient level, but how can we use those data to actually either get more staff, realign or reassign nurses, and begin to think about how we can do a better job to optimize nursing care, not just cut nursing care costs, but optimize our costs in relationship to the quality and the outcomes of that care. Next slide. Just to real briefly mention, we're doing a pilot study here in Denver with some colleagues at Denver Health. One of the problems in measuring nursing care, and especially performance, is it's basically a black box. We know that broadly that there are relationships between low staffing levels and poor outcomes, but what does that mean on a minute-by-minute basis? So one of the things we came up with is using some existing data, these fire hose or these big data sets, and one of the largest fire hose worth of nursing data is medication administration. We calculated on average nurses are giving 1,000 meds per year at this institution. It was 3 million over 2 years, and on a typical day, one of the units was getting 500 to 600 meds. So again, it's this large data set. We have time points. So what we're doing is we're looking at the relationship between nursing workload and the actual delay in administering meds, or when we get outside those boundaries, the plus or minus 30, 60 minutes. So again, it's a way for us to begin to think about coming up with new quality metrics, either performance and quality, in relationship to the real-time environment, the staffing levels, the assignment levels, changes in patient acuity, and so forth. And from that, if we're successful, we're thinking down the line as far as being able to look at things like being able to manage the patient's pain and using pure opioids, other types of interventions, glycemic control, ambulation. So all these are components of good nursing care, and how can we use these real-time data in relationship to the workload, the staffing levels, and so forth to help us identify good nursing care and outcomes of that care. Next slide. So this is just a quick summary. I'll just leave it for you to ponder at this point. I really want to transition to the other presenter. So let me just stop here and introduce Dr. Jack Needleman from the University of California, Los Angeles, UCLA. Go ahead and take it, Jack.
Great. Thank you, John. Next slide, please. I'm going to be speaking about how to create a model for acuity-based systems and talk a little bit at the very end about the business case for these models. I want to begin with a very brief discussion, which John has set up very well, on why acuity-based staffing systems are needed and why they're valuable. So next slide, please. Let's start there. the first reason why these systems are increasingly important is because state legislation is increasingly demanding them. You could argue that the Joint Commission already is demanding something like this, but the enforcement, frankly, has been a little loose. But what we're seeing is state legislation and requirements that mandate appropriate staffing and appropriate staffing systems. The one everybody knows about is California, which has mandated minimum nurse-to-patient ratios. But I would point out those are minimum, and the California regulation, the California statute goes on to say if you need more than the minimum, you better have more than the minimum, and that requires having a system for doing it. There are other state legislation. 7 states are requiring hospitals to have staffing committees responsible for plans and staffing policy, and that means typically having a staffing model in place at the unit level that enables the hospitals to assess whether or not there's what staffing they need. That is basically the model that ANA has been pushing in legislation. There are other modifications of that. Massachusetts has one required to ICU. Minnesota is requiring the CNO or designated develops core staffing with input from others. And 5 states have some form of disclosure or public reporting of staffing. And increasingly, those are going to require both what was your staffing and also what staffing was needed to allow the patients and their families to better assess things. And there's continued pressure to expand this kind of legislation. So just the external demands on hospitals for decent measures of what staffing is needed and how you staff against those models is core. And I think that's part of the recognition that nursing needs to be viewed not as a cost center of hospitals, but as a core service with expectations that it can be delivered reliably and in ways that keep patients safe. And that gets me to the second reason for these systems. Next slide, please, which is that we have substantial and growing body of evidence that efficient care and patient safety require adequate staffing based on patient need. As of 2007, which is where the data on this slide comes from, there were many studies which looked at patient outcomes and length of stay and finds a very clear association between longer length of stay and more adverse outcomes in hospitals that were that had lower staffing levels. And this has been taken as an indication of the need for adequate staffing. Next slide, please. Problem with those studies is they're not causal, and we're not going to have a randomized control trial of staffing. I don't think any of your hospitals are prepared to randomize the staffing on units. The closest we're going to come to a randomized trial is this one that my colleagues and I did and published in the New England Journal in 2011, in which we had a single hospital with an acuity-based system that reported how many hours of nursing care were needed on each unit on each shift. And they also kept track of how many hours were actually provided. And the hospital also could track which patients were in which units on each shift. So we could track patients that encountered short staffing. Next slide, please. And when we looked at patients, we looked specifically at mortality. And what we found is that there was an increased risk of death with greater exposure to lower RN staffing, short staffing units that had shifts that were substantially below what the target amount was. And the numbers that you see here actually look very similar to the numbers that come from the cross-sectional high-staff, low-staff studies. So if somebody says, yeah, but are those studies causal, this is the one to throw on the desk of the skeptic. This study is being replicated in a number of places right now, and I think we'll have more examples of this within hospital variation and its impact on outcomes that people will be able to refer to in the future. Next slide, please. So if the case is made that we need to get the staffing right to keep patients safe and deliver care reliably, what are the factors that go into assessing the right staffing? And as John alluded to, a patient is not a patient is not a patient, and a nurse is not a nurse is not a nurse, and frankly, the unit structure vary substantially and may influence staffing as well. So if you're looking at the factors that influence right staffing, whole series of patient characteristics, their nursing acuity, not their overall acuity, their nursing acuity, their ability to carry out the activities of daily living, their dementia state, their psychosocial needs, their emotional needs, and frankly the needs of their families and others who are involved in their care as well. Nurses also make a difference. The education of the nurse, the experience of the nurse can influence whether or not a nurse is a good match for a patient and how many patients that nurse should be taking on a given shift. And then a whole series of organizational and unit characteristics, including things like the physical layout of the unit. How far people have to go to get supplies, for example, will influence how much staffing is needed on a unit. So these are examples of the factors that have to be taken into account in an acuity system. Next slide, please. That concept of what's going on with the patient is clearly the thing that tends to dominate the acuity models that are out there. And nursing acuity is clearly different from diagnosis, as John pointed out. And here are some of the examples of factors that influence the patient need for nursing care. How many medications they're having, how many procedures the nurses have to carry out on that unit for that patient, what kind of education requirements does the patient and their family have, and what kind of psychosocial support does the patient and their family need. And one example of medications are the role of IV medications in particular, because of the complexity in getting them ready and the complexity of actually administering the drug. So these are examples of the factors that can influence the right staffing and that potentially go into having an acuity-based system that will let us measure the acuity of patients across a unit and determine what kinds of staffing are needed on that unit for that shift. Next slide, please. If you're trying to create such a system, then there are criteria for the system itself. And the first one I would argue is important is parsimony. Nurses have too much to do already, so systems which can minimize the demands on nurses to classify the patients or to assess the patients are clearly advantageous. So parsimony in a system is one of the key factors, and is a system that's going to be workable for us. There's also a need to base it in expert nurse judgment. Nurses understand the care processes better than anybody else. They need to be systems that have a true reflection of the nurse's work, and a variety of indicators that are appropriate to measure patient complexity and the appropriateness of need, and the available other resources in the system. So these are some of the criteria for evaluating different systems. Next slide, please. When we look at the range of systems that are out there, there are commercial systems that you can pick up and adopt, and we also see in the field many locally developed systems. The advantages of the commercial systems are they use an existing algorithm, so you're buying into you don't have to develop your own. They can be calibrated to the local nursing model, and modules can be implemented that allow for the tracking of actual versus target. That 2011 New England Journal article was heavily dependent upon the fact that the academic medical center involved in that research had a commercial system in place. One of the cons of these systems is they tend to be very elaborate in the criteria, the factors that they want collected about each patient, although the vendors have been sensitive to that, and they're increasingly trying to mitigate the data entry burden by linking to the electronic health records. The other thing I noted in a number of these systems is they don't take turnover into account. And I assume staffing is based upon normal turnover, but every now and then you get a shift with very high discharges and admissions, and those impose additional burdens, and those also need to be taken into account in thinking about what the staffing on a unit needs to be for a given shift. The advantages of locally developed systems is that they can be adjusted for local patient variation on specific units or conditions that the nursing staff consider relevant, and they're typically built on a consensus model with the nursing staff, the nursing leadership, coming together with an understanding of how do we think about what our staffing looks like. The cons here are possible data entry burdens because they often have not been automated, and no linkage to tracking data entry and storage. Next slide, please. Let me show you two examples of local models that can be adopted. This is an example of one that came from an article in 2007. You'll notice down the left side here some of the factors they wanted to take into account. Whether there are medications for the patient, the complication of procedures, patient education, psychosocial needs of the patient and their family, and whether there are complicated IVs and meds. And you can see that as you can place the patient in each of these areas on a scale from 1 to 4, and you add it up and you get some measure of the complexity of this patient, some measure of the complexity of all the patients on that shift as a whole, and that gets crosswalked against so how many hours of nursing care do we need on this shift? How many nurses do we need on this shift? Next slide, please. Here's another example of a locally developed system developed in a small hospital in Washington State where as part of a nurse-driven staffing demo. So this hospital started with a grid system for its staffing. So many RNs per patient, so many PCAs per patient, or so many patients per RN, so many PCAs per patient. And then the charge nurses were given the freedom to adjust the staffing based upon the local circumstances. And what you see at the bottom of this slide is the range of things that the nurses decided were important in saying we need an additional RN or we need an additional PCA. And they include such various things as 3 or more patients in isolation, or 3 or more patients that are 1-to-1 feeders, or 2 or more blood transfusions for the RNs. With respect to the PCAs, patients in isolation, patients that are observation, again, feeders showing up there. And this system has been implemented. There are frankly not very many variations from the grid where they've implemented it, but it is the nurses on the unit owning the nurse staffing on that unit, which was a very important thing in this hospital. Next slide, please. So we see in this range of systems a variety of ways of accomplishing estimating the acuity of patients shift by shift and adjusting the nurse staffing accordingly. Question is, I've been asked to comment on the business case, and the question is, so how much is appropriate staffing going to cost? How much more is it going to raise costs to hospitals, and is this affordable? There are 4 published business case analyses that I've identified in the literature in one form or another that estimate the cost of raising nurse staffing to appropriate levels and offsetting those costs with a reduced length of stay and reduced adverse events. This comes from a study that Peter Bierhaus and I did in 2007, and you can see that bringing hospitals up to the top quartile in terms of staffing in our sample had a substantial impact on reducing length days and reducing adverse events and reducing deaths. Those deaths make it clear that the social case for raising nurse staffing to appropriate levels is clearly made. Those systems pay for themselves, taking into full social cost. Next slide, please. What we found, and what others who have done the business case analysis have found, is that they don't quite fully reimburse the hospital for the additional cost of nursing, but they come pretty close, 0.5% additional cost of nursing on average across our whole sample. These look like relatively modest numbers. And if you go to the vendors for the commercial acuity systems, they will haul out their unpublished studies that show additional aspects of the business case for these kinds of models. I would also note that all of the business cases to date do not fully take into account value-based payment. They don't take into account the penalties that hospitals have for lower HCAP scores, or for readmissions, or for hospital-acquired infections. And as we get more and more variables affecting the payment, the business case for bringing nursing up to the appropriate level, I think, is going to become stronger and stronger. Next slide, please. So my closing thoughts on this: other analyses, go talk to the acuity system vendors for additional analyses. The other thing is whether hospitals can retain savings depend on the payment models. And hospitals should want the most inclusive payment models they can get, per admission rather than charges, bundled payments and capitated payments rather than simple per admission charges. So, final closing thoughts. Nursing is a core service line of hospitals, not just a cost center, and should be assessed as a service line. Safe, reliable, effective nursing care depends on staffing at adequate levels, and we have systems, both commercial and locally developed, that can assure that more appropriate levels of staffing matched to patient acuity can be put in place. And with that, let me turn to Sil Trepanier, who's Vice President and Systems CNO of Premier Health. She's going to talk a little bit about their experience implementing these systems.
Good afternoon. Thank you so much. Thank you for having me this afternoon. What I will spend some time sharing with you is our own experience introducing a commercial product to essentially implement all of the great research and evidence that were highlighted for us thus far. Premier Health is a integrated healthcare system located in Southwest Ohio. We are essentially based about 60 miles north of Cincinnati, and we cover somewhere around a 90-mile radius area. The next slide, just to give you a little perspective about who we are. We have 5 locations from an acute care perspective, just roughly a little over 1,900 beds. We have 3 freestanding emergency departments, over 100 sites of services across all of the communities that we serve. Roughly around 14,000 employees. That translates to about 4,500 nurses. We have a fully integrated healthcare chronic health record, which is epic for us, that goes across the continuum. And we have launched our healthcare plan as of January of 2014, just to give a context of who we are. On the next slide, what I am sharing with you is what was the case for change here at Premier Health to implement an acuity system. Clearly, it's very important for us, as many others, that our resources, and particularly our nursing resources, are extremely important to us. They're one of our most important assets that we have here at Premier Health. And taking into consideration our turnover, our vacancy, and more importantly, because our turnover and vacancy is somewhat much better than the national average, but from a workforce planning, everyone is very well aware that the supply of experienced nurses and the supply of nurses is not meeting our demand today, will most likely not meeting our demand tomorrow. And as we look at making sure that we resource all of our various units appropriately so that we can meet the needs of those we serve, we have to make sure that we're utilizing our resources appropriately. And to use our resources appropriately means that and everyone has been saying this for the entire time of this webinar, a patient is not a patient is not a patient. Everyone has different needs, and because they have different needs, and because different nurses have also different competencies, so it's important to have the right match so that we can stage the best possible for those we serve and then meet their needs. And that way we can better demonstrate our value contribution and enhance our business case of caring. It was also important for us to have full clinical integration as we thought about introducing an acuity system. We are in a state, Ohio, which requires for us to have an acuity system of some sort. We had a homegrown acuity system, if you will, and one that required the actual nurse to do a data entry on multiple times during the shift, which at that point was raised a few times, that the more the tool is embedded within the work, the more it's part of the work, and the less it requires additional activities or tasks for the nurse. That's really what we were looking for, something that didn't require much work as possible. And lastly, the case for change was for us to ensure that everyone that comes and seeks services within Premier Health deserves to have the same level of care, if you will, no matter which organization you are, and that the resources available to them would be somewhat equal depending on what their needs are, hence decreasing the variation that we saw, as well as staffing equity. There is, if there is no objective tools to assign patients to nurses, it leaves a lot of subjectivity, and one would wonder whether the assignment is as equitable as it could be for both our patients as well as our nurses. Next slide. So as we identified the proper acuity system for us, we landed on a commercial-based system known as API, currently supported under it's a GE product. It essentially offers full integration with our current electronic health records, and it's a transparent acuity system. What I mean by that is that the nurses do not have to enter and check some boxes giving the system some information about the system that would generate an acuity level, if you will. All the information is, through some very complex algorithm in the background, creates an acuity for any given patient according to the activities that are occurring on this patient, the orders, the medication administration, the admission discharge transfer system, where they're located exactly in the organization, and all of the clinical elements and activities, interaction with family members, anything that's documented in the medical record in the appropriate places generates this acuity for this patient. And then what happens, is, in a very user-friendly ability, allows the nurse, the charge nurse or the team lead, for instance, to appropriately assign the right patient to the proper nurse and see in real time whether that assignment appears to be equitable from a team perspective or not, and then can make the adjustments right there and then. It's timely, actionable data right on the spot. And clearly for us also, it was the ability to find a good faith partner that would really work very closely with us and in deploying the system for us, and making the right changes along the way, because as we all know, very rarely can you find a system and implement as is without asking for some specialization to meet the needs of your specific organization. Next slide. To that end, in order for us to do that, we created a very strong governance around this, so that we could better support its implementation, but also at the same time it would meet the needs of everyone. So having a very strong governance, starting from the system CNO on to many other stakeholders, and really sponsoring this approach. We chose a service line implementation rather than the full bing bang approach. What we mean by that is we identified at first for us was our typical medical surgical unit, if you will. We worked very closely with all of the leaders and also our clinical leaders, our nurses who are touching the people we serve every day, and we worked very closely with them and implemented across all med-surg units across the entire organization, and then we went on to another service line, and that is how we implemented it over here. And clearly, like any other changes in the system, that was yet one more change, although the resistance that was met at the onset was quickly dissipated as soon as the first service line implementation was done, because the nurses very quickly saw that, well, number one, they didn't have to do any additional work, and it gave them tools to appropriately use the workforce that they had on any given shift. On the next slide is describing for you what our future state is. I'm really excited that we will be able to leverage all the work that my colleagues have developed in the business case and the modeling that they've developed, and utilizing that and utilizing our own internal data to further develop the business case of completely changing our budgeting process, utilizing and leveraging the acuity information that we're getting out of the system. So in other words, rather than using a traditional hours per patient day, we will be building a budget that will be based on acuity now that we have a year's worth of data. That exercise was just initiated. We are on a yearly budget cycle. I'm starting our budget for the system right now. So we are already starting to look at that. So it's very exciting work. Difficult work nonetheless, because we're not aware of anyone who's really tackled it from that perspective. So we're trailblazing on this one, and are pretty excited to have the right partner to help us do that. I'm going to now introduce you to our next speaker. I have the pleasure of introducing for you Dr. Carleen Kerfoot. Carleen, it's all yours.
Thank you so much, Phil. I really appreciate your remarks. It's been such a pleasure working with Phil because, as most of you know, he's one of our most innovative leaders that there is in the country right now, and he's especially data-driven. So it really has been a pleasure to be able to work with him in this context. And I really do want to thank John and Jack also for this excellent review of data and opportunities for direction for our future. This is absolutely incredible content that we're hearing today, and it provides us the information that we can use and utilize to really improve care and to improve health care, both for our patients, our organizations, and our staff. There's so much information here, it's almost like the Cliff Notes, but I am assured that you will be able to take this information and turn it into really good content in your individual place. So the question is, why with so much information, so much data, so much evidence, so much going on, we still have opinion-based staffing out there? What is the problem that we can't incorporate data and evidence? And as we know, we have tremendous variability out there. One nurse's opinion about a patient can differ from another nurse's opinion, and we have variation, as our speakers have talked about, in units. So we really can't ignore the data anymore. We really can't staff by opinions. We've really got to staff by the data that's out there. So the question is, where do you go from here? Well, in the next slide, it says that the times are changing. They are changing, and they should be changing. So it's up to us to take the information that we have today and say, oops, there's lots of things going on out there. We need to change. I am reminded of the lyrics from Bob Dylan, where he says, the times they are changing, the times they are changing. John, Jack, and Phil gave us a great picture of the new world that we can create, that we must create, the new world that really drives data, that collects data to drive change versus opinion. So we have it at our fingertips, and we certainly can utilize it. We have the data there. we know that staffing no longer needs to be opinion-driven, no longer needs to be census-driven, that opinion-based staffing really doesn't work because it doesn't pick up the evidence and the research and the data that's out there. So our challenge as we go forward is to really set a stake in the ground that says this should be the end of opinion-based staffing. We require data evidence-driven care from physicians, from nurses, from everybody else, but we haven't yet put a stake in the ground and said we really must have data-driven staffing also. And the point is, you know, we have sufficient data, we have sufficient evidence and technology. It's available, so we need to use it, and the times need to change. So in the next slide, let's talk about what we know. Why change? Our speakers have given us a very clear picture about why we should change and why we have so much better data out there than if we use opinion-based staffing. So we know that, for example, the reimbursement now is tied to clinical outcomes, and we know that staffing is connected to clinical outcomes. We know that organizational excellence is tied into clinical outcomes and excellence in staffing. And we know also that nursing excellence is tied to all this stuff. And Phil has given us a really nice picture about how to operationalize all this and has really created the case for change at Premier. It's our opportunity now to leverage, as Phil noted, our most important asset, our clinical staff, and to optimize, not manage our staff, but to optimize our staff and make sure that they can do the right thing for the right patient at the right time. And then, as Phil talked about, to drive integration. There's plenty of information out there in terms of admission, discharge, transfers. There's plenty of information out there about the unit, about the nursing staff, about the patients, but it's our chance now, it's our obligation to really utilize that data. And the bottom line is we should take a stand to say that we will create equity in staffing, and it will be based on data, on evidence, on science. And then, as Phil noted, that the patients will get the right care at the right time based on data, science, and information that we have. Our problem is we haven't really changed for the last 10 years, 10, 15 years, even though there's been plenty of data out there and plenty of evidence. So we need to say it's time for the next generation of staffing effectiveness. The next generation of staffing effectiveness is acuity-based staffing. And as we look at this slide here, it says the next generation is acuity-based staffing. It's available, it's out there, it collects all kinds of intelligent information and tells us how to be able to staff, and that's what we need to do. The times are changing, and the next generation should be staffing effectiveness. But first of all, as our speakers have talked about, we've got to start with the patient. A patient is not a patient is not a patient. A patient on a grid, there are tremendous differences. A patient that is staffed based on ratio, there's tremendous differences. The electronic health record is the source of truth, so we can go into the electronic health record and eliminate a lot of opinion, a lot of variation about what this patient needs and what the nursing care hours need to be. We also know that an RN is not an RN is not an RN. A new RN believes that he or she needs more time to take care of this patient than an experienced RN, which is true, but depending on who's doing the staffing, you have tremendous variation there. And that we know some nurses are competency trained to do certain kind of patients. They have preference for certain kind of patients. So if we don't look at what the nursing competencies are and match those to the patient needs, we are doing the wrong thing. And if we do it in an opinion-based way, it's not as good as if we can do it with evidence and data. And finally, you know, a unit is not a unit is not a unit. We can bring in admission, discharge, transfer data. We can bring in pending admissions. We can bring in unit characteristics because, for example, this unit might have 30% brand new nurses. They need more staff because brand new nurses can't take care of as many patients as a unit that has people with at least 5 years of experience. So we know that a unit is not a unit is not a unit, and effective systems can pull all of this together to make a huge difference. So we know that the innovation and technology is there. We know that there's national legislation out there that's beginning to address the acuity-based staffing, such as in Massachusetts and other places. We also know that union contracts are now beginning to consider acuity-based staffing, such as the one at Alice in New York. We know that the ANA is developing white papers to facilitate the raising of the bar of staffing processes. And the one that's just come out, the one
Hello, everyone, and it appears that we've lost Carlene. And let me just say we're at the end of our time for today's webinar. I'd like to thank once again our panel of experts who have helped us gain valuable insights about how to understand and use patient acuity to optimize patient care and nursing workload. Remember, you will receive an email within 48 hours containing the webinar recording, and it will be available on AmericanNurseToday.com for 6 months. As we return to our workplaces, let's continue to make evidence-based leading practice common practice. Our patients and our communities are counting on us. And now, for all of us at American Nurse Today, thank you for joining us. Bye-bye, everyone.